Here we go. So one of the things you'd see the most when we hook up the EKG to our students, whenever you move a muscle or laugh or talk, you're going to get an artifact, which an artifact is something that shows up on the EKG that looks abnormal, and it is, but it's not a pathology. It's just an artifact like skeletal muscle depolarization. So it's skeletal muscle artifact. That's the most common. Like this to the left is a normal resting, like no movement. And all of a sudden, maybe the person laughs and you see this depolarization flurry in there. So this is not a pathology. This is skeletal muscle artifact, usually from talking, laughing. Sometimes you move slightly and you'll see that, or breathe a little bit too hard and you'll get that across the strip. So that happens. So the definition of artifact is depolarizations that happen due to muscle contraction, before muscle contraction, that shows up on the EKG. So it looks abnormal, and it is abnormal, but it's not pathological. So it's just that skeletal muscles are depolarizing. So, laughing, breathing can cause artifact. There's other artifacts too. So while we're on this picture and we're recording, this is the difference between standard lead placement and modified. Like we would be doing modified limb lead placement today. And that's the one which was described in the first page. Hold on, see what happened here. Just end the show. Sorry. Go back. So that would just have been the torso electrodes. I say lead placement, but it is electrode placement when you think about it. So this would be limb, a modified limb placement. So they would have the right one would be here. Remember, he owns the anatomy, and the left one, mid-clavicular line. And then the right leg here in the torso, in the groin area, below the navel, pretty much equal with the ASIS. And remember the colors. The left lead is black, the right lead, arm lead is white. The right leg lead is green, and the left leg lead is red. And this is the modified limb placement. Now, next week, we'll do a standard 12 lead EKG, which involves limb leads and chest leads. So the limb leads would go on the wrists, right, which is white, left arm, arm too, don't forget to say arm, left arm is white, left arm is black. And then down the ankle, you'd put the right green electrode, and the left ankle, you'd put the red electrode. And then we'll show you next week how to do the chest leads. And remember, there's 12 electrodes, but I'm sorry, 10 electrodes with 12 leads. So the chest leads go in the chest, obviously, but only one goes to the right side of the sternum. The rest go to the left side of the sternum. So there's V1, V2, V3, V4, V5, and V6. So they kind of go like in this configuration. And we'll learn all about the planes. Like the limb leads are frontal plane, like a clock, frontal plane. And the chest leads are a horizontal plane or transverse or cross section on the horizontal plane. So again, we would have just done the modified limb lead. So please make sure you know the difference between standard limb lead placement and modified limb lead placement. 12 leads, 10 electrodes. You don't have to know the colors for the chest, 6 chest leads and electrodes, but it says it on them. It says V1, V2, V3, V4, V5, and V6. The limb leads are right arm, right leg, left leg, and memorize those colors. So this is a good thing to practice, to make sure you memorize the colors. Now, different body positions, what we would have done, we like to do it this way. It makes sense to have the patient stand for a minute or so, not talking, breathing normally, not taking deep breaths, not laughing. Eyes closed would be best, but it's hard when you're standing up. Then you record the EKG and you print it. And of course, you put the name, like you put Emily is the patient, and this is Emily standing. And then you do sitting down on the cot in the lab, which we haven't even seen yet, with your feet on the floor, 2 minutes. So this is a true 2 minutes of resting. I would say this is a true resting EKG, sitting with your feet on the floor. completely relaxed or normally relaxed. And then you print that, Emily, put her name on it, Emily sitting, all at rest. Then you have Emily lie down for a minute or so on her back. That's supine, lying on your back, face up. So all of these, and then you do the EKG and you label it Emily laying down, supine. All these three are called static. You're not moving, you're just standing, sitting, and lying down. This one down here is a dynamic exercise. Dynamic meaning there's going to be moving involved. So what happens here is you lay down for a minute, then you get up really quickly and take the EKG right away. So you're laying down for at least a minute. It should be more than a minute actually. And then the heart rate, of course, is going to be low. And then when she stands up really quick, you record the heart rate and then print it. And that should have increased dramatically to the highest of the heart rates. So if I asked you which of these four has the slowest heart rate, which one would you say? Would it be sitting, standing, supine, or the dynamic one? Really? Anybody know?
Supine?
Yeah, it would be, for sure. For sure. Very good. And which would be the fastest?
Dynamic?
Yeah, it is. You're correct. So this is kind of what you'd see. And this is a very slow heart rate. I think if we did the top, like this is A, that's really slow, B, C, and D. Now these are all getting progressively faster. Look at the R wave distances. Just by looking at them, you can see that. But that's no way to evaluate. But it's pretty obvious. And they're all regular rhythms, as should all the rhythms of the students we do. So A has a very slow heart rate. Like if you did the 300, 100, I'm sorry, 300, right, 300, 150, 100, 75, 60, 50, 47, 43, you're down below 40 here. So this is less than 40 beats per minute, supine. So this is the supine one. Everybody see that? Now, why is it so slow? This is important. You really have to pay attention here, or at least give me the right answers if you can. So there has to be some type of sensing of blood pressure, which is directly related to the heart rate. So if the heart rate goes up, so does the blood pressure. So when you're lying on your back, your body generally thinks that your blood pressure is great because you're not against gravity. You understand? There's no gravity because you're laying down. So the blood is pumping out of the left ventricle into the aorta with good volume and good pressure, really good flow volume. It's really bombarding that aorta. So the aorta, the aortic arch and the carotid sinus have receptors for pressure. Do you know what those receptors are called? Like what's the prefix for pressure?
Is that a baroreceptor?
That's a baroreceptor. So that's really great. Thank you, Isaac. So the baroreceptors are getting bombarded with blood. So the baroreceptors don't need to send a signal to the medulla oblongata to increase the heart rate through sympathetic stimulation. You don't need sympathetic stimulation because you're laying down and the baroreceptors are getting bombarded. They're getting stimulated, really. So it doesn't need to send a signal. So now when you stand up or sit up, now you're working against gravity. So standing is more gravity than sitting. So of course the heart rate is going to increase more originally with standing than it would with lying down and even sitting. Sitting would also increase the heart rate because of the baroreceptor response. Because once the blood flow changes and the baroreceptors are getting bombarded less, that's when it sends the signal to the medulla oblongata, which sends out a sympathetic stimulation to the SA node, the AV node, and the heart muscle itself to speed up and increase the force of contraction. You understand that? So you need sympathetic tone to get the cardiac output back from laying to standing, or else you're not going to get the blood to the brain fast enough, and you may have syncope and get dizzy and fall down. So when we're doing this in class, you should have a chair nearby, and the students should really be watching to make sure that doesn't happen because it's pretty common. where the sympathetic nervous system doesn't kick in fast enough. Does that make sense?
Yeah.
Yeah, it's like when the baroreceptors don't feel the bombardment, they don't get stimulated, that's when the signal is sent. And that's the hardest thing to understand. So B, actually, let me ask you, which one of these do you think is the sitting position? Second low, that would be this one, right? This would be Emily's sitting. And then we look at her EKG, we make sure it's regular, which we know it is already from looking at the first one. And then we would make sure that there's a normal P and PR interval, normal QRS and T following each other regularly. Then we do the heart rate. So I think this is the same EKG we saw before. Which beat would you start the 300, 150, 100 method on? And there's 1, 2, 3, 4, 5, 6, 7, 8. Which one would you start on?
5.
Yeah, I would too. So again, we do the 300, and remember, this is the starting point, this R, 300, 150, 100, 75. So it's close, it's between 75 and 100. Now this is a 6-second strip, so we could have just done 8 times 10 and got 80, but that's too approximate. So we did the 300, 150, 100, and we got something between 75 and 100, but closer to 75. So that makes sense. Then we could do the RR interval. We could take 3 boxes, that's 15 plus 2, maybe 2 or 3. We won't split that hair, so it would be 15, 16, 18. So I would divide 1500 divided by 18, or I would multiply 18 times 0.04 and divide that into 60. So we'll probably get like 83, I think, 83 beats per minute around there, or 84. And I'm not going to split hairs on 2 or 3 beats or boxes. Does that make sense, sitting?
Yeah.
And it'll tell you on the EKG machine, but it's important that we learn how to do this. Sometimes you have to figure it out quickly, and it doesn't tell you. The next one would be Emily standing. And we could do the same thing. It's going to be regular. We know it's regular. We look for the P waves. They're nice. They're sexy. And then QRSs are all normal. PR intervals are all normal. But you notice that the RR intervals are a little shorter. The RR waves are closer to each other. So we'll pick out a good one. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. And we look for the one that's closest. Which one do you like? Which one would you pick for the 300, 150, 100 method? Which beat looks the closest to the thick line? I think there's 2 of them that are good. What would you choose? Maybe 3.
2.
Yeah, you can start with 2. So this, remember, this is the starting point. Then 300, 150, 100. So it's between 100 and 150. If we did the 6-second strip, it'd be 130, right? 13 times 10. And then we could do the RR interval method, which is 5, 10, maybe 11. I would say 11 divided into 150, or 11 times 0.04 divided into 60. So it's around 130 beats per minute, right? You could do the math. And that's completely expected because she's under sympathetic stimulation. She's standing now. She's not resting. And she stood up for only a minute, right, at this point. Now, the last one is the dynamic with getting up quick. And stand up quick, I should say, from supine to standing very quickly. So now you can see that this is fast. You can pretty much see a P wave. It's on top of the T. Actually, this phenomenon right here is called P on T phenomenon. So there is a P wave there. And we know it's there because we already saw her EKG at different places. Can it change when she exercises? Yes, that's why we do exercise stress tests. So we have to be careful. We have to look at all 12 leads, make sure all parts of the heart are okay. But we know she's good. we're just looking for heart rate here. And we already kind of know the rhythm. So same thing, you can count the waves, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14. So it's a little faster than the other one if this is a 6-second strip. So notice the boxes are a little smaller looking than these, so it's very relative. So I would have to tell you that this is a 6-second strip. So here the baroreceptors kicked in nicely. It increased the heart rate to, what are we going to pick here? Let's start at 4, 7. I would start on this one and I would do 300, 150. So the heart rate is 150 beats per minute. You feeling comfortable with this? Being able to do that? BPM, that's BPM. So that's completely appropriate, 150 BPM with a quick get up. Now her heart rate's going to drop back to the normal standing. It should drop to this very quickly. And the more she stands and relaxes, it should go down. So this is the resting heart rate that I would use for her baseline if I had to write it in a chart, because it's sitting with her feet on the floor. Everybody okay with that? You have to understand the concept of baroreceptors. So when the baroreceptors aren't being stimulated, that's when they send the signal to increase the heart rate via the sympathetic nervous system. And remember, the sympathetic nervous system releases a neurotransmitter to the SA node, the AV node, and the muscle itself, the heart muscle itself. So sympathetic stimulation affects the two nodes by increasing the action potentials to increase heart rate. And also the sympathetic nervous system affects the contractility of the heart and makes the heart beat stronger with more force. So the neurotransmitter used to the effector, which is the heart, the SA node, AV node, and the myocardium, is norepinephrine. In parasympathetic, where she was lying supine, completely parasympathetic, the parasympathetic nervous system uses a cranial nerve, which is cranial nerve 10, called the vagus nerve. And that releases acetylcholine to the AV node and the SA node. Doesn't affect contractility. So the sympathetic does affect contractility where parasympathetic does not. So in parasympathetic stimulation, like lying supine, the vagus nerve is going to release an inhibitory neurotransmitter to the SA node to slow down heart rate, less action potentials per minute. Same thing with the AV node, but there's no effect on the contractility. So it's very sympathetic oriented because it's really important to get your blood pressure up when you need it. So again, you looked at those, you saw this. Now remember, the different static body positions were just sitting, standing, and lying supine. So the slowest of the static was the supine, of course, but the fastest was standing because the dynamic was not static. There's a difference. That's why I pointed that out later, so you answered this question correctly. And then you talk about baroreceptors, right? And the gravity that has to be overcome to get the cardiac output from your left ventricle into your aorta to your brain. So, because your brain controls everything. Very important. So again, the sympathetic changes that go on here is important. So you have to read through this. And when you get the book, it'll make sense. Now, the Valsalva maneuver is basically holding your breath and bearing down like you're delivering a baby, right? Or bowel movement, or really straining without breathing. So you close off your glottis and really bear down. So it's easy to do when you're bent in this position because it really increases the intrathoracic pressure. So what Valsalva maneuver does, and you shouldn't do this more than 10 to 20 seconds because it's kind of dangerous. So the Valsalva maneuver basically drops the heart rate. So it's a maneuver that's vagal. It'll drop the heart rate, parasympathetic. It'll put you in parasympathetic. The problem is it's increasing your aortic pressure because you're holding your breath and you're blocking the glottis and you're basically closing the valves. So, or when the valves are closed, it's really an issue because now the heart has to pump against more pressure. So it's an inverse or reciprocating situation. So this is what you need to know. The heart rate drops, especially in the first phase, and the aortic pressure increases, which is okay unless it continues. But then it reciprocates, and then the heart rate goes back up, and the aortic pressure comes down in the second phase. So in a healthy person, this is fine. But then at the end, your heart rate's going to drop again, and your mean arterial pressure is going to go up in your aorta. So again, it's reciprocating these two. But really, the takeaway here is that the Valsalva maneuver will lower your heart rate. It decreases heart rate. And it's used to do that, exactly that. Now, here's just a picture of the brain and the brain stem, the acceleratory and inhibitory cardio centers in the medulla oblongata, where there's also a vasomotor center for your blood vessels. So here's the receptors in the carotid sinus and the aortic arch that sense that there's no blood flowing in there, will activate the sympathetic nervous system, which will send out a signal back to the SA node, the AV node, and all the muscle. Where parasympathetic is just using the vagus nerve. So know where the baroreceptors are, know how they're stimulated, and what the outcome is. And you'll learn a bit of this in lecture too. So, but the concept is very important that you understand. When you're laying down on your back, there's plenty of blood hitting those baroreceptors. There's no need to activate the sympathetic nervous system. But when you stand up, there's no stimulation to the baroreceptors, and that's when the signal is sent. It's like if your refrigerator is empty, you call your mother to buy more food. But when it's full, you're okay for the rest of the day. So the baroreceptor is very important. In lab, we could have done a little exercise heart rate. Maybe we could go on the treadmill for a couple of minutes, right? And then like we'll do this for an exercise stress test, which you're on the treadmill for at least 15 minutes. And then you do the heart rate, you do it before on the EKG, then you do it during and after to see how basically seeing how your heart rate decreases after you get off the treadmill. So this is basically what's happening. Like right here is your baseline heart rate, a little bit over 72. Then when you get on the treadmill, your heart rate can go up to as high as 160. Then you get off the treadmill and it should drop back to your resting heart rate. And there's a time period like this down here is time, with in seconds or minutes, whatever you need. And right here is your blood pressure, heart rate. So going from 70 to 160, and how long it takes to go from like the peak to here. So you're measuring this time really, and how long that takes. And the faster that can happen, the better, and the better cardiovascular health you're in if your heart rate goes back to resting quicker. And it depends on your age and gender, and size, and health. Now, the mammalian diving reflex is basically, we're mammals, right? So what happens with the diving reflex, and this is all about cold water. When you're exposed to cold water, like when the seal dives into the cold water, the heart rate drops very fast, very fast. Like first it's high coming into the water. Once it hits the cold water, the heart rate will drop down drastically, faster than it would under normal circumstances without the cold water. So that's a pretty cool situation. Now this one, we put you on a treadmill. Again, you'd have your resting heart rate. You'd get it up to 160. And right here is where you add the cold towel or dump a cold bucket of ice water. So we'll just say cold water. So now the decrease in the heart rate is much steeper than it was without the cold water. So you overlap those and you can see how the difference in time. Like this is basically where the heart rate went to 160, and this is the amount of time it took with the cold water, and this is the amount of time it took with the warm or with a normal circumstance. So there's a big difference right in here. So the mammalian diving reflex drops your heart rate much quicker than without it, and that's what that reflex is all about. And we're mammals. We have fur, we have nipples, we have little bones in our ears, we have teeth, we carry our young in our uterus. So it works for us as well as seals and other mammals. And that's really all that means. So now what we're going to do here, and we do this in lab, carotid sinus massage or pressure. And this is a tachycardia. If you look on this side, this is a very fast heart rate. So what we do is we rubby-dubby the baroreceptor with our fingers of the patient, and that'll slow the heart rate down. So we can see if there's a P wave. This one's pretty difficult. This is lead 2. So there's some things going on here that are abnormal. So there's another one coming up, which is better. Let me take you to that one just so you can see. Right here's a good one. So what this is showing is a tachycardia on this side. So I can't really see if there's a P wave because the P is probably lost in the T. And if you do the heart rate here, you can see it's 300, 150. It's closer to 300. So it's 280. Who knows? You could do that math right now. You could count the 5, maybe 6, 7, and divide that into 150. It's a very fast heart rate. It's tachycardia, but I don't know where it's coming from. I don't know if it's a sinus tachycardia or if it's coming from another source like the atrial cells or the AV node. So now we massage the baroreceptors and the rate slows down temporarily. It could be a treatment, but it's not a fix for tachycardia. It's definitely tachycardia. I just don't know where it's coming from. So now we can see that there's a P wave and a normal PR interval and a normal QRS. So this is going to be sinus tachycardia. And that's what we call that. Now, we can't call it sinus here because you can't see it. All you see is this big T wave between the R's. And you know it's tachycardia, but you can't tell if it's sinus tachycardia or atrial tachycardia or accelerated junctional rhythm, all those things you'll learn later. You kind of understand that?
Yeah.
So like when you see that on EKG, like say you're looking at EKG and you see that tachycardia that we saw on the left side of that picture, you can't, and the doctor asks you what's going on, all you could say is supraventricular tachycardia, which is SVT, which means because the QRS complex is normal, it's not coming from the ventricles, the cadence, it's coming from above the ventricles, like it could be the SA node where it's starting, it could be the atrial cells, it could be the AV node. So all you could say there is supraventricular tachycardia, SVT. But then when you did then you'll say, okay, do carotid massage or Valsalva or mammalian diving reflex and see if you can slow down the heart rate enough to see if there's a P wave. So you did carotid massage and the heart rate slowed down, and you can count the heart rate, what it slowed down to. And then you saw the P wave and you saw it was normal. You saw that the PR interval was normal. So now you could say this tachycardia is coming from the SA node. It's sinus tachycardia. Do you understand that? Really important.
Yeah.
That's really important. That's a really good concept right there. SVT, because that'll come up again when we do rhythms, SVT. So it's good that you're exposed to it now. Okay, let's go back to that. Talk about some other rhythms and rates. And we could do breathing. You could do deep breathing and holding your breath. And you can see what happens to the heart rate as it increases when you do holding your breath and breathing shallow, like hyperventilating. Deep breathing is not fast breathing. It's breathing in, inhaling and exhaling deeply. Not completely forced, but deep and slow. So again, we'd follow these instructions. We'd go through it all. And then we take a look, we'd see what the difference is. So again, this could be a shallow breathing. And you notice that the line is kind of wavy. And it's okay that the R waves are upside down because we're looking at lead V1, which is not looking at the left lateral wall of the left ventricle. It's looking at a completely different area. So that'll make sense later. So don't worry about that. Just look at the rhythm. It's regular and you can see it's wavy. That's because the person's breathing. And so their chest muscles, pectoralis, are contracting. The next one is just normal. It looks fine. There's nothing going on there. This is probably one we've seen already. So you can do the heart rate. You can start here with the 300, 150, 175. Everything is regular. You know that there's a normal P wave and there's a normal PR interval. Now let's look at this one. This is the one really what I want to show you today before we go and really understand what's going on here. So take a look at this one for a couple of seconds, for 10 seconds or so, or 15 seconds. And look to see if you see anything. I'll give you a couple of seconds just to look at it. Okay, so what do we find out? First of all, is this regular? Like if you did your calipers and you moved them over, would they line up all the way across?
No.
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 Excellent. That's right. You're right. You're 100% right. So it's irregular. Everybody agree?
Yeah.
Now, from what I can see, this is a little more difficult, but you can see that it speeds up, slows down, speeds up, slows down, speeds up, slows down, and it's happening kind of regularly. So this is called a regularly irregular rhythm, but it's still irregular no matter how you slice it. It's irregular. Can we agree on that?
Yeah.
So you probably can't, you shouldn't use the RR method here. You should use a 6-second strip, but this is not a 6-second strip. The other thing you should know about this, and I didn't tell you this, is that this is a person doing deep breathing. They're breathing in and breathing out rhythmically, deeply, not normal breaths. So right here is inhalation, and this is exhalation. So inhalation increases the heart rate, exhalation decreases it. And that happens with every breath in line. So during inhalation, the sympathetic nervous system kicks in. During exhalation, the sympathetic nervous system is inhibited, or parasympathetic takes over, basically. Everybody understand that? Now, let's take a look. And is there a normal P wave on every beat? Yes or no?
Yes.
Yeah, there's a P wave there, and it is normal. Yeah, it is. I agree. And the PR interval is normal every time. Is there any skipped QRSs? That's a good question. Do you see anything skipped? Is it PQRST every time? And how many beats do you see here total? About 14? 14, yeah.
Yeah.
So do you see PQRST every time?
Yes.
Yeah, you do. It's always a P followed by QRS and a T. And the QRS is normal. Even though it looks thin, it's normal, completely normal. So this is not normal sinus rhythm, but it is sinus rhythm. So this is called sinus arrhythmia. It's regularly irregular, and it has to do with respiratory changes. And it's benign. It's not going to hurt this person. They might not even have any symptoms. So this is the only arrhythmia that you'll see in sinus rhythm, where the SA node is doing the job, just that the sympathetic nervous system takes over. Benign means it's not dangerous. So remember that. Valsalva maneuver would lower the heart rate. So kind of know what Valsalva is. Yeah, and the physiological effects. And we talked in good detail about the carotid sinus pressure or carotid sinus massage, which can be very dangerous if somebody has blockage in the carotid artery, like a thrombus or something. So you want to make sure you have a crash cart nearby if you're going to do this in a hospital. But of course, doing it to a student who's completely healthy is not, probably wouldn't even change the heart rate that much. But it could be dramatic in somebody who has a heart condition, especially a tachycardia, which you know every time, because you know what cardiac output is. Anybody who has a problem with their heart, stroke volume or contractility, is going to be in tachycardia. So the heart makes up for the loss of cardiac output. So be careful. So like I said before, if you can't see a P wave, you see that big hill, this is called SVT, supraventricular tachycardia. And then after the massage, we saw there was a P wave, normal QRS and T, and the PR interval is normal all the way through. And it is regular. Even in the tachycardia state, it's regular. It's not irregular. It's just tachycardia. And it happens to be sinus tachycardia. If there was no P wave, right, between these, like say it looked like this, QRS, and then another QRS, another QRS. If there's no P wave, chances are this is going to be a junctional rhythm, like junctional tachycardia or accelerated junctional rhythm. because junctional means the AV node is starting the cadence, not the SA node. So you have to have a P wave that's sexy in order to call the sinus rhythm. Whether it's tachycardia, bradycardia, or arrhythmia, the P wave has to be there and has to be sexy. And the P wave has to be followed by a normal PR interval and a normal QRS. I can't stress that enough. To call it sinus rhythm, whether it's normal sinus rhythm, sinus tachycardia, sinus bradycardia, sinus arrhythmia, all of them have one thing in common, or three things in common, really. They have a normal P wave, they have a normal PR interval, and a normal QRS complex. And there's no missed QRSs, because then you're dealing with something else like an AV block. Yeah, and supraventricular tachycardia means that the cadence is starting from above the ventricles. Because if it was ventricular tachycardia, this is what ventricular tachycardia looks like. It's just reciprocating T and R waves. No P wave, no PR interval, nothing. Just, and this is a problem, ventricular tachycardia. It means the ventricles are the ones that are starting the pace, not the SA node, not the atrial cells, not the AV node. The AV node is not working in ventricular tachycardia. And if you have ventricular tachycardia, it's going to turn into this, which is ventricular fibrillation. And if you have ventricular fibrillation for too long, you're going to have a flat line, which is asystole, which is no heart rate, and that's cardiac arrest. So usually VFib will turn to VTAC is this. VTAC will turn to VFib, and then asystole if you're not defibrillated. So sorry, systole, flatline. But the SVT is not a ventricular rhythm. That's above the ventricles. That's the point. So here's all the questions about carotid sinus massage and what baroreceptors are. You should have a good idea. Again, the clinical conditions where carotid pressure is used is really for tachycardia, SVT, sinus tachycardia. It's really about lowering the heart rate. That's all it is. Okay, now these are just problems that we might have seen. And the most common is artifact. Like this is a skeletal muscle artifact here. And it's pretty obvious. That's not a pathology. This is normal right here. And this one is backwards, you see? It's like you made a copy for your lab partner and it showed up backwards, like the T is in front of the QRS and the P follows it. That's not, I guess, an artifact, yeah, but it's a mistake. This one is just not enough voltage, probably. So you didn't calibrate the machine correctly, or the leads weren't secured, or the electrodes weren't secured. This one's a little wacky. This is a problem with interference from the outlet that you plug the machine into, like 60 cycle interference. You can listen to this if you want, if you're able to listen to Professor Liberty's narration, if you can get it. I don't know if it works for Macs, but it works for PCs if you want to listen to it. This is just a problem. You just tape you covered the EKG with a piece of tape. You're taping it into your lab manual and you messed it up. This is breathing or laughing. You might, just be moving the line around, which is very common. Nothing wrong with that EKG. This one obviously is you put the electrodes on the opposite poles, the opposite part. You put the right leg on the left, the left leg on the right arm, and you mixed them up so it came out upside down. This one, obviously, all the leads fell off, all the electrodes fell off. So these are limb leads 1, 2, and 3. You can't get any readout. So you have to redo it, that's all. Believe it or not, usually the first time the students do it, it works out great. So this is lead 2 is not showing anything because the lead fell off. Probably the lead fell off the left leg. So one of the leads fell off is the thing. And this thing, either there's a big problem with this person, they have no cardiac output, just a little QRS there, or whatever that is, or you did something wrong with the setting the frequency of the machine, or the leads aren't put on correctly. But the most common that we'll ask is going to be like skeletal muscle artifact, like the picture we saw before. Let's see if we can find that one again. It's kind of common. Went the wrong way here. The skeletal muscle, you saw it before. Anyway, let me go to the next thing I forgot to talk about. Now, this is therapeutic hypothermia. And this happens when the patient is in cardiac arrest and you cool down their blood by like 6 degrees Celsius less than body temperature or blood temperature. And then you apply ice packs and ice cooling helmets, cooling blankets. You can inject a cooling solution that lowers your body temperature. And the whole idea about this is because if you're in cardiac arrest, you're not pumping oxygenated blood to the brain. So you only have a certain amount of time before you become a carrot, right? Before you become brain dead. So this buys you time by decreasing the metabolic demand of the brain for oxygen, glucose, and other nutrients. And this could give you time to treat the patient for the cardiac arrest. So of course, it'd be much more efficient if this happens, in the hospital, right? If somebody goes through a cardiac arrest and you treat them with therapeutic hypothermia. I just want to go back to see if I can find that thing to show you. I forget where it was. Yeah, right here. So this is a common middle of the road artifact. Like everything is fine until you start laughing or moving. And that's skeletal muscle artifact. And then the other one, I think is a pretty good example, is the other artifact, which is kind of like this, where it's kind of waving. And this is very common. You see that happen, very common. And this is just some examples of how you name the waves. We can do this in the SEC. Like you can see there's a P wave there. So this is a P QRS complex, or you really just see the P in the R wave. This one you see a Q wave and an R wave and no S. This one you see R and S. So this would be RS. It's kind of a difficult one. This one is QRS, PQRS. But I'm just really asking about the QRS interval. So this one, I can't really see the P wave. So this is Q. I only see the Q and S. This one's called the QS because there's no R wave. Like this one is a QS because they're only negative. Remember, the Q and S waves are negative. The R wave is the only positive one. It's a tough one right here, but I think that's a QRS. And this one is just RS. Seen there. This is a tough one. This is an elevated ST segment. Sometimes they call that ST segment elevation myocardial infarction, which is a heart attack, really, STEMI. ST elevation myocardial infarction. So you can see the Q wave, you see the R wave, and you really don't see the S wave really, because it doesn't get negative. So it's really just QR. But this is a problem, it's a pathology. So take a look at some of these in the lab manual when you get them, take a look at the handout and practice them. And some of the ones you have difficulty with, you just come into the SEC with me or Joshua or Patricia before the next exam or quiz. But the next exam or quiz is going to be about heart rate. So be comfortable with heart rate. And I'll give you a heads up to what the quiz is about before Friday.